Welcome to This is Growing Old, the podcast all about the common human experience of aging. My name is Adina Lasser, and I'll be your host. There's no easy way to process grief. Grief is unpredictable and uncomfortable, sometimes messy, and always painful. We're about to experience grief many times in our lives, and more often as we grow older and witness the health of our loved ones decline. So why not prepare for it? Joining us today are two guests who have made it their mission to improve the palliative and end-of-life care experience, aiding families and patients with the transition into a comfortable and dignified last phase of life. Carol Fisher, president of the National Partnership for Healthcare and Hospice Innovation, is a relentless advocate for health equity and social justice. As president of NPHI, Carol rallies more than 100 not-for-profit organizations around transformational innovation in end-of-life care. Tom Kasumpis is the CEO and co-founder of NPHI. Like Carol, Tom is committed to innovating advanced illnesses and hospice and palliative care. Tom is a prominent leader on issues related to Medicare, elder care, advanced illness, and hospice care with a career that spans several decades. Carol and Tom, thank you both so much for joining us.
Oh, thank you so much. It's great to be with you.
Thank you, Adina. We're looking forward to this. Thanks for having us.
Absolutely, we are too. I'll go ahead and jump in with our first question, which is, I think, part of the reason that we're gathered together today. August 30th is Grief Awareness Day, which is a time to educate people on grief and create space for loss. Can you tell us more about the role of end-of-life care in preparing a patient's family or loved ones for the grieving stage?
It's so wonderful that you're acknowledging and recognizing Grief Awareness Day. It's such an important day. And I think, I'll kick off by saying that there's this misconception often about hospice and palliative care that it just benefits the patient. But in fact, hospice embraces everyone in the family. It really helps caregivers and supports them. And, in hospice care, it's not just addressing someone from a medical perspective, but it's helping people from an emotional perspective and a spiritual perspective. And I say all that because I know Tom and I like to say, with all the things that are challenging in healthcare today, hospice and palliative care is really what's right in healthcare. And that includes the commitment for bereaved. And so what people often don't realize is that family members, after their loved one passes away under the care of hospice, those family members are entitled to support for 1 year following the death. And that's really important because grief, as we know, comes in many different stages and forms. And it's not just a 1 day, a 1 month, a 2-month occurrence. In fact, it's often more than a year. But we're here, our members are here to support people who've lost a loved one. And we do that in a couple different ways. We do that in individual support settings. We do that in group support settings, just many different ways to help support a family and a loved one. But Tom, I don't know, you have anything you want to add at that?
Yeah, I would just add as well, Carol, I think it's important to know that we also provide that support, not just after the patient's deceased, but ongoing during the process. Very oftentimes people begin grieving almost immediately, and particularly if they're the caregiver. And as they go through that process, we're there to support them all during it. So that kind of support, I think, is very important and helpful to families that have a hard time dealing with it, that are struggling as they are providing the care and support as the caregiver. So we're there from the beginning, as Carol said, for a year after even. So it's a long period of support, which is really critical.
It's an excellent point too, because Adina, what you might be interested to know is that our members, so we have 100 plus members, hospices throughout the country, and they go above and beyond in providing that support. So they often find themselves honoring special wishes that their loved one or a patient has, really supporting the loved one of the people that are grieving. And so that might look like, we had a patient once, I know there's a story about they wanted to see their horse one more time, and found a way, that hospice found a way to bring the horse to that patient and spend time petting and touching the patient. It was such a lovely experience. I mean, there's just tons of examples of, weddings that happen for family members, and they have a wedding in a patient's room, whether that's at home or an inpatient setting. And just to make sure that that loved one can attend. I don't know, Tom, what do you think? So
Oh,
many
no.
wonderful examples.
Yeah, there are so many. And another example is our children, supporting children who have lost parents or lost a family member, and really creating that support for the child, which is so critical because they often are not just bereaved, but emotionally really distressed. So it really spans the gamut in the ways that we support people through the grief process.
In fact, many of our members offer grief support camps during the summer.
Yeah, that's right.
Yeah, for children. And it's just wonderful that children have a place to come together and to know that they're not alone. So often people just feel alone, especially children. And so they come together as groups and do therapeutic and fun activities to help process that grief.
We're the only benefit in Medicare that actually requires that sort of support. And I think that's important to note as well. When the Medicare hospice benefit was designed, it included incorporating grief support, grief counseling, included having a social worker and a counselor on your care team as well. And all of that's part of the requirement. And that's really a very distinguishing factor for the benefit within the Medicare arena.
Wow, and I know that you both work so hard, and it sounds like make a huge difference in people's lives, and that's fascinating to hear about Medicare. And maybe we can dive into that a little bit more later in the podcast. I did want to ask Tom, you shared recently in the Wall Street Journal that a personal experience with death led you to this work. Can you tell us more about that if you're comfortable, and what being CEO of this organization means to you?
Oh, absolutely. Thank you for that. Well, yes, I think personal experience drives so much of what we do and the passion for all of us. So at a very young age, I was a staff member in the United States Senate for Senator Birch Bayh from Indiana. Senator Bayh was a very important senator and was at the time authoring 2 constitutional amendments to the United States Constitution. His wife and he and his wife and family were very close family friends. We were originally from Indiana, and my family moved to Washington very early on at my age. And I began working just out of high school, and then all through college. I went to Georgetown University, worked in Senator Bayh's staff for about 12 years. During that time, I became a health aide as one of my responsibilities for the senator. And during that course of that time, his wife passed away at a very young age. She was 47. She had gotten breast cancer at age 42 and lived about 5 years. But, think about it. And now as I'm older, and I think about a 42-year-old woman getting breast cancer, beautiful woman, just extraordinary, beautiful inside and out, and was very close to me. She was the first person that I had ever been close to that had passed away. And that experience really drove my interest in end-of-life care. And it was interesting and sort of simultaneous to that. So she actually passed away at the National Cancer Institute as part of NIH, and she was hooked up to, all sorts of life-saving things and just every kind of thing that they could provide to try to extend her life, none of which was working. And, frankly, it was a horrible death because she was isolated in a hospital room, without her family around her, except for her husband. Her son and I were actually off-site when she passed, and we didn't hear about it till after. We actually heard about it. This is interesting. She was the wife of a United States Senator. We heard about it on the national news. We were sitting watching the national news, and CBS came out with a bulletin and said that Marvella Bayh had passed away from cancer. So the whole experience was just extraordinarily awful. Very sort of simultaneous to that time, there was a lot of information flowing from the UK to the US to our Department of Health and Human Services about the idea of hospice care. And that sort of propelled me to get interested. The person who was actually coordinating that was someone that I knew, a former congressman from Palm Beach, Florida, who they used to call Mr. Health here in Washington. He was such a driver in healthcare reform. And he called me and said, Marbella's death was so traumatic for you, and I know how interested you are in the whole system or lack of system that we have. Would you be interested in working with me to develop this concept from the UK in putting together a hospice benefit in the US? And that's how I got involved. And that was the beginning of which I've been involved ever since. But it was that personal passion that led me to, we can do better, and we can make this something that families can experience with their loved ones, not isolated in a hospital room with no one around. And that's just been the driving force for me.
And when you were working on that, did you participate as the health aide or in a different capacity?
So I left the Senate in my capacity in the Senate. Senator Bai actually left office in 1980. And so that I went over and worked for the law firm, which is a law firm in Washington called Hogan and Hartson Law Firm. And they had been tasked by the Department of Health and Human Services to put all of this together. And so I worked directly for the firm that then worked with the Department of Health and Human Services. We had, I think there were 26 pilot sites where we were testing the idea and of the hospice care benefit. And a lot of our work began in Florida, which was the first state that had a state hospice licensure law as well. So 26 pilot sites. One of them happened to be here in Washington, which is Capital Caring. At the time, it was the Hospice of Northern Virginia. I ultimately went on to be the CEO of Capital Caring Health here in Washington many, many years after, but they were one of the original pilot sites. They tested the concept. It was successful, just overwhelmingly successful. And as a result, then the benefit developed and grew. And now, of course, about half of Medicare beneficiaries participate in hospice at the end of life.
That's incredible. And Carol, I know you've also dedicated your career to addressing end-of-life care issues. Can you talk a little bit about how you got into it and then how this field has evolved since beginning your journey as an advocate?
I spent my career working in not-for-profit and for-profit settings, and my background's actually in social work, Adina. And I realized, 20 some years ago that I wanted to make sure that I was doing meaningful work. If I'm going to get up and make contributions every day, then they should be of purpose. And so I joined Nathan Adelson Hospice in Las Vegas, and within a year became their president and CEO. And it was just such an honor to be at the helm of such a fine organization, and now have the privilege of serving under Tom's leadership as president for MPHI. So it's just been a great journey, but we've seen so much change. And I think Tom, when he created this benefit with some folks, never expected the kind of growth and the tremendous, now what we see as profiteering of the benefit. So things have really changed a lot. Just in my 20 some years of being in this part of healthcare to, Tom's 40 plus of being in this part of healthcare, just significant change. And some of it's very disappointing. We're looking at business models that may not be consistent with best practice for the patient and their loved ones, and making sure that their grief is supported fully. So it's been an incredible journey, but we're certainly faced with some disappointments today, aren't we, Tom?
We are indeed. I think, as you said, Carol, it's been an incredible journey, and certainly so many good things. So many people have had the opportunity to be cared for in the right way at the end of life. Like anything, as it grows, you need to make sure and address its growth issues, and I think that's where we are at the point in the context of timing with the benefit. We have it has grown, developed, and now we're looking at how do we address some of the growth issues? How do we make some changes that will make sure? And our goal in PHI is to make sure that the benefit is provided in the highest quality way, that patients and families get all of the kind of care that we originally envisioned, and to make sure that that continues.
Well, and where do you think those kind of downgrades are coming from? And if you want to, we also have a question about kind of the congressional work that MPHI does, and I think that might all fit together. So I'd love to open it up to discuss that as well.
Yeah, I think the biggest issue, like so many in our lives, it's profiteering and money. I think that there's been such a growth in the number of providers because they recognize that if you look at the demographics, the number of aging people, the aging population is growing dramatically. Obviously, the population that will need hospice care is growing dramatically. So the business opportunity from their perspective is quite positive. And that has really driven so much of the concerns that we're seeing and the kinds of manipulation of the benefit to make excessive profits, as easily as possible. And that's what we're fighting hard to stop and to protect and make sure that particularly our not-for-profit community-based programs thrive into the future, provide that highest level of care, and that we stop this profiteering. That's really what's driving it.
Carol, did you have any thoughts on that?
Well, we have one chance, one opportunity to help someone die well. There are no do-overs. And so it's really important. And our members are so committed to our 100 members. We care collectively, gosh, for 60,000 patients each and every day. Not just hospice, but palliative care too. And our members are so committed to doing the right thing at the right time for the right reasons, and making sure that we're always paying attention to loved ones, back to the purpose of this podcast about grief, and paying close attention to that. And anybody that works at the bedside is an amazing human being. So if they're working for a for-profit or not for profit, we think the world of people who help people at the bedside. But the business models are different, and we're working really hard with our team and educating on the Hill to make sure that there is a clear understanding that mission-driven care really puts people over profits.
Yes.
And that commitment will always be honored.
Yes.
And choosing end-of-life care for a loved one, going back to that grief aspect that you mentioned, it's never easy. What is your organization doing to support families in making this incredibly difficult decision?
Well, we have many resources available, and I would suggest that people can come to our website. It's hospiceinnovations.org. Certainly reach out on our toll-free number if they're looking for help. And that's 844-438-6744. And we have tools and resources to help people make good decisions. But, it's a critical time when you're making a decision at hospice, for hospice and end-of-life care. So asking good questions about expectations in terms of availability, 24 hours a day, 7 days a week. Sometimes asking someone else, friends and family, if they know of that hospice is really important. Looking for their length of time that they've been providing the service, I would think, is really important to weed out some of the players that come in and just open up to sell, and then they're only there a couple of years.
And we certainly, all of our colleagues will do whatever it takes to support a family who's trying to make the decision. I think, once they reach out to us, we can immediately, and we do immediately, not just respond, but really surround them with information, with the opportunity to ask questions. I recently, and this was just an extraordinary event that occurred in my life just a few weeks ago, had this wonderful young couple who contacted me and said that their father had a stroke and was debilitated and was really thinking that he needed hospice care. He was in a rehabilitation center, but it wasn't going well, and he was really declining. And they were just lost. They said, we really just don't know what to do. His wife was not well as well, although she was living at home. And so it was hard for her to make any kind of decision. And they said, we just never engaged in anything like this, and we're stressed, and it's really awful. So I got with our chief clinical officer, and she got them, met with them, walked through all of the things that we could do to support them. And they called me about 2 or 3 days later in tears and said, nobody was helping us during this process until you came along, until we got in touch with you, not just me, but my organization. And your colleague was a lifesaver. And the father enrolled in hospice, and they're now caring for him. And it made all the difference in that family's world. And there were 3 brothers and sisters, and they were all young, and they were all really distressed. And in the middle of all of that, the mother died of an aneurysm. So all of this within about a 10-day period. And it was just one of those heartbreaking stories that you almost can't talk about. But I'm really proud of our hospice people, because they did what they needed to do, which is they just took over, they surrounded them. They ultimately are being cared for now in a way that they said they've never been cared for. So I think that's what each and every one of our members at NPHI do. Don't you, Carol? I mean, it's a normal thing for us. There's probably not a week goes by that someone doesn't call and want to talk about a referral. How do I get help? Who should I call? And that's just an ongoing part of what we do. So as answering your question about how we support, all of our colleagues do that throughout the nation. And that really means tremendous amount to families, obviously.
We hear a common theme, our members hear a common theme, and that is after a family chooses hospice, one of our members support, the family will often say, I wish I would have reached out sooner. I wish I would have known about you sooner. And it's just a common, right? I see you smiling, Tom. It's just a common response. Yeah.
It is. It's the number one response we get. Oh my gosh.
Yeah. If only I would have known. So
Yes.
it's our members really love being of service, and they're always available 24/7. And we're here to support. And it's very common that Tom gets a phone call like that. I get a phone call like that. All of us do. So
Yes.
it's just always a privilege to help others.
Well, and I'm thinking, for a lot of people, hopefully, this is something they go through very few times in their life, and just to have someone experienced in their corner and helping them out, I'm sure makes such a huge difference.
Yes, absolutely.
And could you talk about some of the biggest misconceptions about hospice and palliative care, and maybe even the difference between the two for some of our listeners that might not know?
Well, one of the you go, Tom.
No, go ahead, Carol. You're up.
Well, one of the big misconceptions is that we hospice hastens death, and it just doesn't. What were you thinking, Tom?
I was the same thing. That's the first response that I always have is, it's not giving up. It's not hastening death. In fact, it's just the opposite. We see, and there are clear statistics that show that when people are under hospice care, they live longer. They are pain-free, or try to be pain-free. They have the emotional support. The caregiver has support. So all of the kind of things that we do actually extend life. And that's a very common part of hospice care. It's not at all about giving up. It's about living the best life you can through the end of life. And that's really, I think that is the biggest misconception.
Yeah. And another one is that you can't sustain and keep a relationship with your primary care physician. And that's just not true. You very much can. We respect those relationships, and you're not asked to give anything up in terms of a relationship with your primary care doc.
Well, and in fact, if during the course of treatment of support, you decided it wasn't what you wanted, you can certainly leave as well. So, that's another misconception. Well, if I choose hospice, then, I can't do anything else if I wanted to. And that's not true at all either.
Yeah. Another one is that hospice is a place, and it's not. It's a philosophy of care. And what's wonderful about hospice is we go to wherever that patient is. So if that patient wants to be cared for in their actual home or someone else's home or a nursing home, wherever that patient resides is where our members provide that care. Our members provide care in prison systems, in sometimes for homeless people.
Yeah.
So wherever that patient resides, we're willing to go.
And we often do have inpatient units in addition to our home care. The great majority of care is provided, as Carol said, in the home, wherever that may be. And then we do have, for very sort of difficult cases to manage, where there's really pain and symptom management is challenging, we have inpatient units as well. But the great majority are home.
And I like what you said. I thought that was fascinating about it's a philosophy. Could you talk a little more about what that philosophy is and, when it might make sense for some patients?
All right, which one's going? Go ahead, Tom.
The philosophy is really, a comprehensive care for the patient and the family. So when we built the benefit, it was really important that it be provided by an interdisciplinary team, and that you had a team, a doctor, a nurse, social worker, psychosocial, spiritual support. The only benefit in Medicare as well that has spiritual component that's a part of it, and the use of volunteers. And all of that was designed to create a team that would not over medicalize your care, but humanize your care. And that's really what's important. It's looking at the patient as a person, and addressing physical symptoms, psychosocial symptoms, family dynamic issues, all of the above, to make the end of life as good as it can be. And I think that philosophy is what drives our passion. It's to make sure that the person and their family are embraced, are surrounded by care and love. And I think that is the extraordinary philosophy.
Carol, anything to add there?
No, I think Tom said that beautifully.
Yeah. And this just sounds amazing. And I know that other organizations and members of the community are going to be really interested in getting involved. And I know you mentioned a couple of resources for families as well. You mentioned that NPHI is home to over 100 not-for-profit, community-integrated hospice and palliative care providers, and we're counting up. How can our organizations and advocates become members of NPHI? And what can we do to help and get involved?
Carol, you want to take that?
Yeah, well, we're always interested in mission-driven, like-minded hospice and palliative care providers, and they can reach out to us and
Yes.
apply for membership. We also love working with organizations that are complementary. So we have relationships with the American Heart Association, the American Lung Association. We work with the Hospital Association. Tom has great partnerships with the AARP. Oh my gosh, the list goes on and on, whether it's CAPC or I don't, right? The list is endless.
Absolutely.
Yeah.
Yes. So anyone interested, email us or call us. We really always are excited about the opportunity to work with like-minded providers, like-minded organizations that share the same philosophy or the same approach to care delivery. And we would really welcome that opportunity.
Wonderful. All right, well, this has been amazing. I'm going to turn to our closing questions that we like to ask all of our guests. And the first one, and Carol asked, I'll start with you. When you were a kid, what did you imagine growing older would look like?
Oh my gosh. Well, I here I am growing older. Yeah. I always wanted to, my family instilled a very pay it forward, generous spirit and taking care of other people. So I have spent my entire professional and personal life doing that. And that's, it's just a privilege today to be part of helping people die well and live well up until the very end of their actual physical life, and then supporting people during their stages of grief. So yeah, that I think I'm living my dream of what it's like to age well. How about you, Tom?
Yeah, no, I think that was a great answer. I think the same way. I think, well, first of all, sometimes you have to pinch yourself to think you're actually aging, because I still feel as though I'm, a 20-year-old, and I enjoy that. But I also think that with the aging has come the wisdom, and I think that wisdom helps you to create a balance for your life, and certainly from my perspective, like Carol just described, has sort of driven me to work in the field that I'm working in, and being able to do what I can do to make a difference in the lives of others. And I think as I've aged, I think it's happening the way I sort of envisioned it, and I'm enjoying it, and I just appreciate the opportunity to keep providing that kind of support to others, and hopefully will for a lot longer as well.
Yeah, absolutely. And finally, what do you enjoy most about growing older now? I'll let either of you start.
Oh gosh.
Well, I think that wisdom that we've gotten from aging helps us to lead a more balanced life, maybe being a little bit smarter about things, and but it also, the experience of all that I've had during my life has given me the opportunity to, I think, be more open, more caring, and so many good traits have come as a result of aging that it's made me the person I am today. And hopefully that is an important part of the aging process that is a good part of it.
No, anything from you?
Well, gosh, I'm actually hitting Medicare age on Wednesday, so I'm turning 65.
Happy
And
birthday!
yeah, I know, right? Right on your podcaster. I think that as I'm aging, what I'm realizing is that it's really important that we own our story, and that we stay true to ourselves and true to our loved ones, our families, and our close friends, and that it's okay to say no. It's okay to set boundaries for yourself, and so I'm enjoying this part of my journey in my life, because I am probably more confident and feel a little bit more capable than I ever have. So it's a great question, though.
It is a good question.
That's incredible to hear. All right, well, I'm going to wrap things up, but thank you both so much for joining us and for the incredibly important and meaningful work that you do. We really appreciate you being on the podcast. And for everyone listening, thank you for listening to This Is Growing Old. If you're enjoying the show, please subscribe wherever you get your podcasts. And if you'd like to learn more about NPHI, be sure to visit them at hospiceinnovations.org. Have a wonderful day.
Thank you so much.
Thanks, Adina.